Namaskar. Good morning. I am Dr. Seema Garg and I am going to speak about graft preparation and storage. So nothing to declare, no conflict of interest. Steps of hair transplantation are harvesting of the grafts, then preparation and processing, then graft storage, and the last is the implantation or the placement of the graft. So today we are going to talk about the middle step, that is the graft preparation and graft storage. So we start with the graft preparation. Graft preparation is the journey of the hair follicle from the source of production to the destination, that is implantation over the recipient area. The aim of graft preparation is to optimize the graft for implantation to achieve the best outcome in hair transplant procedures. Now, characteristic of a healthy graft are, it should be well hydrated, so there should be no signs of desiccation, intact sebaceous gland and the bulge, and intact perifollicular tissue and peribulbar tissue along with the intact shaft and bulb. The production of graft from donor area are by two processes. One is by FUT, that is linear strip excision process, in which a strip of skin from the occipital safe donor area is harvested and the individual grafts are prepared from the donor strip. Another method is by FUE, that is follicular unit excision, in which individual unit of follicle and or group of follicles are excised. So first we see the preparation of graft from the strip, that is by FUT. Now graft production after strip harvesting is a vital component of hair transplantation. It is a microsurgery and needs good hand-eye coordination, patience and training. Magnification is essential during all the steps of graft production. Hair follicles are very delicate and sensitive to microtrauma and desiccation. And this graft production by strip method has two components, slivering and follicular unit production. So various magnifications which we can use for slivering and follicle dissections, we can use simple optical glasses or magnifying lenses with light, prismatic loop or stereo microscope. Stereo microscope and prismatic loop are the best because they have depth perception also. Preparation of sliver from the strip. Once the surgeon excises the strip from the safe donor area of the scalp, it is divided into small pieces and given to 2 to 3 assistants for slivering. From small pieces of strip, slivers are created. So, for production of individual graft from the sliver must be of very high quality. For the high quality of sliver means the width of the sliver must be 1 follicular unit thickness. So, from this strip, we can dissect the graft. And for this, we have to stretch the sliver, then place body of the scalpel in between the two follicles, keep stretching the sliver and pull knife towards you. So here is the video showing all these steps. The most important point is we have to keep hydrated the tissue. And for this, we can use moist gauze to wrap the strip. Then hold the skin edge with the forceps, keep it stretched, and with the help of the scalpel, we dissect the intradermal fat. So, by keeping the skin stretched, we create a dissection plane, and by dissecting the intradermal fat, we can create a very good high quality sliver, thickness of which is either 2 mm or 1 single follicular unit thickness. And magnification is very important for all these steps. Stereo microscope is used. Again, you are seeing this sliver creation. So, with the help of the forceps, the edge of the skin is held with the non-dominant hand. And with the dominant hand, we use the scalpel, and with the tip of the scalpel, we are dissecting the intradermal fat. Now, here you can see lot of fat is there below the bulb. This extra fat we need to trim. But we have to keep in mind that if more amount of fat is excised, then there can be the damage to the bulb. So this point we have to take care, and here you can see this is the longitudinal sliver. The extra amount of fat is trimmed off, and now we will create the graft from this longitudinal sliver. Now this individual graft dissection is done again with the help of this scalpel. Some surgeons, they prefer the razor blade. So basically sharp instrument is needed depending upon the choice of the surgeon. And this extra tissue is removed from the graft. Now the ideal graft should be of pear-shaped. So there should be sufficient amount of the peribulbar tissue below the bulb of the follicle. And here you can see the grafts are so well hydrated, and during all this process we keep irrigating the tissue to prevent the dehydration and desiccation. And these are the grafts of the FUT. They are the depithelized graft. Now we come to the second process, that is the FUE grafts. So after incision of individual follicular unit with the help of a punch, graft shall be removed from the donor area safely to avoid trauma to the delicate graft. Remove grafts preferably using 2 forceps technique method to avoid injuries like capping, desheathing, plucking, fracture of the graft, iatrogenic splaying, and crushing of the bulb of the hair follicle. And all these grafts after removal, they shall be examined under magnification for various injury. Now this is the video showing the follicular unit excision method. So with the help of a punch, we are incising the skin, and then the grafts are removed with the help of the forceps. So here you can see the grafts. Then this is 2 forceps technique method, and during all this procedure we are irrigating the grafts with the saline, and you can see it is so well hydrated, good quality grafts. Now this is the graft from the beard. So beard harvesting, and again you can see one assistant is removing the graft with the help of 2 forceps technique. So these are the chest grafts. Chest grafts are very delicate. So after incising with the help of the punch, they are again removed with the help of 2 forceps. Now microtrauma to the graft. Rough handling of the grafts during extraction, processing and implantation may induce microtrauma to the hair follicle cells. Hair follicle cells are very delicate, and physical trauma may directly kill the cells, which may affect the outcome of the hair transplantation. So a study was done by the Gendelman et al. To see the effect of physical injury on the hair follicle under electron microscope. It also contributes the dehydration, and injury to the hair follicles grossly affect the morphology of the hair follicles. Now the examination of the grafts. So microscopic graft processing is essential for quality control and quality improvement. Grafts need to be counted and separated by the number of the follicular units. So single follicular unit, 2 follicular, or the family units. So transactions and other damage to the follicles need to be counted and recorded. Occasional grafts will have irregularities that may impede placement and need scalpel trimming. Now, Dr. Robert True divides the graft into 4 classes depending upon their quality. So the graft quality index depends on the characteristic like splay, transaction, denuded follicle, graft margin, and supportive tissue and tissue below the bulb. So in class 1, the grafts are with abundant supportive tissue and peribulbar tissue with smooth and regular margin, no denuded follicle and no transaction, and if splay is there, it is only the structural splay. Class 2 follicles are same as the class 1, but with no tissue below the bulb. So peribulbar tissue is absent in class 2 grafts. In class 3 grafts, there is extreme iatrogenic splaying. It means there were forceful removal of the graft because of the shallow punching, and this result into the extreme iatrogenic splaying with some amount of transaction also. Denuded follicles are common. There is no supportive tissue, no peribulbar tissue, and the follicles are bare. In class 4, there is more common transactions with splaying, iatrogenic splaying, irregular borders, irregular supportive tissue, and no peribulbar tissue. So this is the graft quality index. Now to calculate the graft quality index score, following method is suggested. 1 point is assigned to each grade 1 graft, 2 points for grade 2 graft, 3 for grade 3 graft, and 4 points for the grade 4 grafts. Now the point total is divided by the graft total to get the graft quality index. Lower scores indicate more grafts with the most favorable characteristics, easiest to place and more likely to survive. Higher score above 2 imply more graft with less favorable characteristics, more difficult to place without risk of trauma, and more likely to have lower graft survival rates. So, rough handling of the graft results into the physical trauma to the graft, and it may lead to desheathing, fractures, complete and partial transections, crushing of the bulb, capping, plucking, and iatrogenic splaying. Now, after careful examination for all these injuries and knowing the graft quality, the grafts are to be sorted and stored in petri dish. Sorting of the graft is done as per the number of the follicular unit, like single follicular unit, 2 follicular unit grafts, 3 follicular unit grafts, and family units. Sometimes surgeons want to trim the epidermal part of the graft to have better cosmetic appearance. So advantage for this is a shallow implantation of a graft having large epidermal island may give cobblestone deformity. So trimming reduces chances of cobblestoning. But if trimming is not done carefully using good magnification, there may be damage to the vital part of the follicle like sebaceous gland and bulge. The injury to this vital part may compromise the outcome of the hair transplant. Now pairing of the graft. If there are greater number of single follicular units, in such cases, 2 follicles can be implanted in same site. This is known as recombinant grafting. The pairing can be done using 2 single follicular unit graft or 1 single and 1 2 follicular unit graft or 2 double follicular unit grafts. Now this will help to increase the number of multi-follicular units for getting better cosmetic density. Now, if there are not enough number of single hair follicle unit graft for anterior hairline and for temporal fringe reconstruction, in such cases, the interfollicular dissection of multifollicular unit is done to have single follicular units. And this shall be done under good magnification to avoid injury to the vital part of the hair follicle. The single follicular unit grafts to be placed most anteriorly shall be carefully examined for the presence of vellus-like or the telogen hair, because when grafts having telogen or vellus-like hair are implanted, they may give rise to multiple hair growth and it may look unnatural. So now these are the prepared graft, FUT, FUE, abdominal, chest and the beard grafts which are ready for the implantation with well-preserved perifollicular tissue, sebaceous gland, bulge stem cells, and there is extra fat around the abdominal and the chest hair grafts as they are very delicate and sensitive to micro trauma and desiccation. Now we come to the second part, that is the graft storage. So the time interval between the graft being harvested from the body and implanted back is the time where hair follicle cells are cut off from the circulation, supply of oxygen and various nutrients. This period is known as the out-of-body time or the ischemia time. During this period, graft is kept or stored in a solution called the graft holding solution. Now in this entire process of graft preparation and graft storage, graft may suffer from injuries like ischemic injury, cold injury, ischemic reperfusion injury, desiccation injuries and microtrauma during handling of the graft. And the success of the growth of hair depends on minimization of this injury. So these are the hair follicle injury. We can divide them into 3 headings: macroscopic, that is the transection injuries; microscopic, desiccation and direct microtraumas; and the metabolic injuries, that is ischemic, cold injuries and the reperfusion injury. So by cutting off the circulation of a hair follicle, the aerobic production of ATP and elimination of the metabolites are stopped. Also, the supply of essential nutrient is cut off, which produces injury to the rapidly dividing cells of the hair follicle. Now, if the restoration of the supply of oxygen and nutrition is not done, hair follicles, rapidly dividing cells, may undergo apoptosis. They may not produce the hair at all or of poor quality. Lemur did a study in which grafts were stored in cold saline and implanted at different intervals. So here you can see at 2 hours, 4 hours, 6 hours and so on. So he found that survival of graft steadily decreases when grafts are stored between 2 to 48 hours. Then we come to the cold injury. We all know that metabolism of cells depend on the temperature. So lowering the temperature lowers the oxygen demand of a cell. Oxygen consumption at 5 degrees centigrade is about 6% of the oxygen consumption at 37 degrees. But the benefit of low temperature will be limited by a process known as cold injury. Lower temperature affects the permeability of the cell membrane. So it causes membrane ATP, sodium and potassium pump to be disrupted. Influx of sodium attracts water into the cell, leading to cell swelling and increases the calcium in the cell that activates degenerative enzymes. So there is a study by Kim and Hong, and in this study, the survival of the graft was decreased when grafts were stored in chilled saline because of the cold injury. Now this cold injury can be controlled by maintaining the oncotic pressure of the graft holding solution. Increased oncotic pressure will prevent cell swelling even at low temperature, and which is needed for the reduction in cell metabolism and oxygen demand. So chilled hypothermosol solution are graft storage solutions that prevent this problem. Now the study of Biner, he found that storage in chilled hypothermosol and ATP improves the survival of graft exposed to crush injury. So he kept some grafts into the chilled saline, some into the chilled hypothermosol with ATP, and he found that after 2 hours, the growth of the graft is 90% in chilled hypothermosol as compared to the 74% in the chilled normal saline. Now we come to the ischemic reperfusion injury. During the ischemic condition, the hypoxanthine formation takes place in graft cells, which when re-exposed to oxygen after transplant in the live tissue result in the formation of free radical, which damages the cells and DNA. This injury is known as the ischemic reperfusion injury. When grafts are stored in a hypothermosol solution, the formation of free radical is reduced, thereby reducing this injury. A desiccation injury, another potential source of injury, is drying of the graft while out of the body. Graft must be kept fully covered by the graft holding solution to prevent this desiccation injury. Drying being almost immediately starts when the grafts are exposed to air. Within a matter of few minutes, the drying can damage the graft, resulting in poor growth when transplanted. So a study was done by Hong et al. To see the effect of dehydration, room temperature and the grafts if kept at 4 degrees centigrade on hair follicle. This study concluded that dehydration and temperature at which grafts are kept outside the body affect the graft survival. So an ideal graft storage solution should minimize this ischemic, cold and reperfusion injury by maintaining appropriate oncotic ionic balance, appropriate pH, preventing acidosis, formation of free radicals and oxidative stress. The solution should also provide substrates for regeneration of high energy compound like adenosine triphosphate. So there are two types of graft holding solution. One is the extracellular. It includes intravenous fluids like saline, ringer lactate and culture media, autologous plasma and PRP. The another is intracellular graft holding solutions, and they include tissue preservation solutions which have been specially designed to hold tissue during chilled storage condition. Hypothermosol with ATP is the example of intracellular graft holding solution. Now the extracellular solutions are isotonic in nature. and are composed of ingredients similar to plasma and the extracellular environment of the cells. So we can see there is high concentration of sodium and low potassium in extracellular graft holding solutions. These solutions should not be chilled, as chilling may lead to pump failure of the cell membrane, leading to an influx of sodium, which will cause cell to swell. The intracellular graft holding solutions are hypertonic solutions, having the composition and ingredients similar to the intracellular fluid. So they have low sodium and high potassium ion concentration and larger anions that are unable to cross the cell membrane. These solutions provide osmotic support. Higher osmotic pressure prevents the influx of sodium and water, and those cells do not swell because of chilling. The example of intracellular graft holding solution are the hypothermosol, which is the most commonly used. Some other fluids are also available, and according to the study by Matthews et al., when grafts are stored in intracellular graft holding solutions, they should be chilled between 4 to 9 degrees centigrade. Cooley's study have shown that grafts kept in hypothermosol with liposomal ATP can survive even after 5 days of the storage. Now, use of plasma and platelet-rich plasma as graft holding media, as the autologous plasma and PRP have various nutrients, antibodies, and platelet-derived growth factors. So, the plasma used by Ubal et al., Greco, and Garg has shown beneficial results in terms of early growth, increased density, and thickness of hair in their studies. The prothrombin present in plasma help to form 3D fibrin scaffold in which activated platelets are present. These platelets release various growth factors. So the 3D fibrin scaffold provides a biological protective three-dimensional covering with platelet growth factors. Autologous plasma is extracellular in nature, so it do not require chilling. Now, this is the list of various graft holding solutions with pH and osmolality. So, human plasma, normal saline, lactated ringer, plasma light, they all are extracellular in nature, and the hypothermosol is intracellular. We should not use sterile water as it has zero osmolality and will cause cells to swell up, and ultimately cells die. So, the extracellular fluid like normal saline and ringer lactate can be used as a graft holding solution when graft out of body time is less than 2 hours. These extracellular fluids should not be chilled, and when grafts are implanted immediately or within 2 hours of graft out of body time, the survival of grafts remains the same irrespective of the type of graft holding solution. In large procedures in which grafts will be out of the body for longer than 2 hours, then the use of chilled hypothermosol solution with ATP improves graft survival. So for optimal growth of transplanted hair follicle, minimize graft out of body time less than 2 hours, minimize trauma to the graft during harvesting, graft processing and implantation, minimize damage to the circulation of the recipient area bed while creating recipient sites, place graft at proper depth, prevent graft desiccation by continuous saline spray during extraction and implantation of the graft, and keep grafts well covered by the graft holding solution. Maintain the required temperature as per the graft holding solution and transfer the graft to the holding solution immediately after extraction. These are my references, and thank you.